Hello, this is your lecture on the respiratory system. Let's get started. The respiratory system's main function is gas exchange. It ventilates the lungs with fresh air, then uses the circulatory system to circulate the respiratory gases, O2 and CO2, very long distances. Let me see. Now, when I say it ventilates the lungs with fresh air, pretty much it's the alveolar spaces, these microscopic air sacs that you can't see obviously here, but we'll take a look at that in histology. So it ventilates the lungs, alveolar spaces with fresh air, and uses the circulatory system to transport the gases, which are O2, CO2, long distances. Oops, one of my things. So this is the classic anatomy respiratory system picture with the guy's head turned to the side and the chest cavity exposed. Basically, for the anatomy, we can excuse me, divide the respiratory tract into the upper respiratory tract and the lower respiratory tract. The upper respiratory tract includes nasal cavities, starting right here, going to the pharynx and then the larynx, which is your voice box. Pharynx is basically your throat, larynx is basically your voice box. And larynx is pretty much the border between upper and lower respiratory tract. So And so basically you have your main airway, the trachea, your largest airway. So the large airways include the trachea, but also here you can see a division here, and you can see the bronchi, the right and left main bronchus going into the lung. So bronchus, big airways. Bronchus is singular, but you have more than one, so bronchi is plural. And so these larger airways that transport the air, the fresh air that you breathe in to the lungs, deep into the lung tissue, are called the conducting airways. There's no gas exchange that occurs there. They just conduct the air. So the larger airways, like these guys here, call the conducting airways. So consider them large airways. They conduct air, but they don't accomplish gas exchange. The smaller airways are like called bronchioles. You can kind of control these. They have a lot of smooth muscles. The main difference between larger airways and these smaller airways, the smaller airways have no cartilage. The larger airways have cartilage. The cartilage is the stiff tissue and it kind of helps to keep the airways open, as we'll get into later. And the smallest airways, like I said, are the alveolar spaces. Okay. And it's basically the upper respiratory tract where you have cold and sore throat. And down here, maybe you have pneumonia, bronchitis, and this is kind of where if uh, the virus that causes COVID-19 gets, it can cause lethal problems. All right. So this lecture focuses primarily on the anatomy and histology of this system. So let's kind of start with how you inhale air and follow the air all the way down deep into the lung tissue. And we'll start with the nasal cavities and the pharynx. So in this picture here, you can see where the airway starts. And people know you can breathe through your nose or your mouth, but we don't teach the mouth as part of the airway. Um, you intubate through the oral cavity, you can. You can basically breathe through it, but if you're all stuffed up here and you have to breathe through your mouth, I think you've noticed it's very uncomfortable. You get dry mouth, and the air should be ventilated through the nose. So your nose, or the anterior nares, is where it starts. Basically, in your nose, you have hair that can kind of catch some of the debris you're breathing in. Hair follicles. And get into the nasal cavities. Which you see in this picture here with the conchi. Superior, middle, inferior conchi, which help break up the airflow. And you get right here, call that posterior nares, anterior, posterior nares. Just think of the posterior nares, this is imaginary border that leads into the pharynx. As we can see from this picture, the pharynx has three subdivisions. Naso-oro-laryngopharynx, as you can see color-coded right there, your throat. So know those three subdivisions of the pharynx. Here's a more anatomically correct picture of the pharynx. It's a beautiful picture. Let's kind of blow up this area, the pharynx right here, since that's what we're talking about. And right there, what I have circled in green is the orifice to the auditory tube. So what I have there is the orifice to the auditory tube, this little orifice right here. This is a side view, lateral view. It's an orifice is important because it connects the ear, nose, and throat. Here it is from the front view right there. Where I'm pointing right there is right there. So you can see there's the middle ear, the tympanic cavity, and that's basically your ear. So that's your ear. And this is your throat. And right above there is your nasal cavity. So they're all connected. And well, that's important to know. I mean, there's ENT specialists because if it's all connected, it's how infection can spread. Other things to know, there's some lymph tissue here. Basically, we call them your tonsils. What's highlighted in green there is the pharyngeal tonsil. Just kind of add that. We'll list it as a thing to know. Remember, we call it tonsil. It's basically lymph tissue, how it helps fight infection. And this picture here, you can see the adenoids or the palatine tonsils, as we call them in anatomy. If those get infected, they get really big, and you can see them if you have a tongue depressor. All right, well, anyways. So I have it highlighted in green here. The little archways that go over it there, little archways, there's a uvula. These archways are called the fauces. I'm just going to write located within. Fauces. These little membranous archways, and the adenoids are kind of in between them there. Well, anyways, moving on. You also have lingual tonsil highlighted in green. Now in the picture there, lingual, pharyngeal, palatal tonsils all highlighted in yellow in that illustration. Okay. Here's another picture of the pharynx. Okay, this picture is a posterior view. Here's the side view that we're used to. You can do a thing where you kind of cut that ligament there. Here's the vertebral column. You can separate the head, neck, larynx off of the vertebral column, as we've done here, and you can, just cut the pharynx and just here's the pharynx just cut open, so we can see the concha, the nasal septum there. We can see the uvula, the root of the tongue, and we can see the entrance into the larynx, and that's what we're going to talk about next. The main functions of the larynx is voice production. It has the vocal cords, as we'll see, but it also guards the airway during swallowing. So that inlet, it's the route for food. I'm sorry, it's the route for air. The route for food as you swallow food should go down posterior to the airway, which is the esophagus. That's the food way. The airway, as you breathe air in, should go down from the laryngopharynx into the larynx, right there. You can see the laryngeal inlet right there. In this picture here, it has the mucous membrane over cartilage. That's basically what the larynx is, your stiff voice box. You could palpate yours right there, right? In man, the Adam's apple is right there. And we can see some little bumps here created by cartilage. And there's a couple of little bumps that are always on your anatomy list, and you shouldn't write them down here. These two here, the cuneiform tubercle and the corniculate tubercle. Write those down. Structures to know. In, in anatomy, tubercle means bump. So these are basically bumps created by the cartilage kind of poking the membrane and kind of like make the bump. But you should be able to identify those two little bumps right there. So basically, to make sense of what the larynx is with this picture, usually in anatomy labs, we have just models of just the cartilage. You kind of strip away the mucous membrane that covers it, and boom, that's what it looks like. I kind of put them side by side so you can kind of see the posterior view of your voice box dissected out of the mucous membrane. It's a cartilaginous structure. It's your voice box. And the reason why it guards the airway is this flap of cartilage called the epiglottis. When you swallow food, it comes down and it guards the airway, which is right here, called the glottis. So I'll call it the epiglottis. Covers or guards the glottis during swallowing. The glottis is your quote unquote airway. Here's another picture of a model we have in the lab, and I want to show it to you here since we're online. You can see how the mucous membrane is still there, but they kind of strip it away right there, so you can see the bluish cartilage underneath it. Okay, and on this picture here, you should be able to identify cuneiform tubercles, corniculate tubercles. There's a number 3 there, and there's an arytenoid cartilage. We'll look at these other cartilages. I have better pictures of them later. But root of the tongue, you can see how it all matches up. Here's a side view of that same model that we have. And here's another picture. I took this picture and I tilted it so it kind of matches how the larynx is located in the basic, we call it the anterior neck. The posterior neck would be the vertebral column, the cervical vertebra. There are other epiglottic, there are other laryngeal cartilages to know. There's a lot of cartilages and there's a lot of muscles. I focus mostly on the cartilages. We have to know them all, and just a couple of laryngeal muscles. Because when you talk, your larynx moves a bit for voice production. We'll get into that. Let's focus on the cartilages now. So far, you got cuneiform tubercle, corniculate tubercles, which are formed by cartilages. The main cartilage is the thyroid cartilage. Let me take a picture of this and start fresh. So what I have written on the whiteboard is the thyroid cartilage. It's a big shield-shaped cartilage. In fact, the word thyroid, it means shield. And the thyroid gland that we studied in endocrine is actually named after this cartilage. This little point right there, where I'm pointing, I have written on the board, Laryngeal prominence, or the Adam's apple as in males. Um, Women have an Adam's apple. Well, we don't really call it that in women because we wouldn't call it the Adam's apple. But that's kind of why men have deeper voices. I think this may have some testosterone receptors to make it larger, to make your voice resonate a little deeper in men. Now, so know the laryngeal prominence, don't call it the Adam's apple. Also know the cricoid cartilage. That one's shaped like a ring. Imagine a big class ring. That's the band of the ring, and that's the face of the ring there, and there it is there in the larynx and isolated. So be able to identify the cricoid cartilage, and that space between thyroid and cricoid, that's kind of where if you have to cut the person's throat because they're not breathing, maybe there's an obstruction up here somewhere, and you can make a cut there and insert something so that they can ventilate through there so you can save their life. Obviously, if you're an ENT or another kind of first responder, you might be trained to do that. Um, I have not been trained to do that. I just kind of know that's where you go to cut through the soft tissue to open an airway so you can save someone's life. Okay, let's look at other views of the larynx. Try to make as many views as possible since we don't have this model to work with in the lab. And there's the superior view. And you can see in the superior view, we have the vocal ligaments, which run from the thyroid to the arytenoid cartilages, which you can see here. So let's note the arytenoid cartilages. They're paired. Vocal ligaments, commonly called the vocal cords, run from, as you can see from that picture, thyroid cartilage. I'll just say thyroid to arytenoid cartilages. So you got your paired arytenoid cartilages, cricoid, thyroid cartilages. Also note these little horn tips. Those are the corniculate cartilages, which form the corniculate tubercle. So I'll squeeze them in on the bottom here. They form the corniculate tubercles of the same name. So continuing on, what I have written on the board, the space between the vocal ligaments is the glottis, your airway, right here. So it's the space between them. And if the first responders have to intubate through your oral cavity, they try to aim and get the airway tube down between a little upside down V right there to insert an airway tube so you can breathe. Because evidently you're not breathing, so you need help. You need to be intubated. Well, here's a cut view of a full head neck specimen and just the larynx. And what we see in this picture here, there are actually two ligaments, a top one and a bottom one. So let's kind of talk about that. The top one is it's called the vestibular ligament, and the bottom one is for voice production, so I call it the vocal ligament. So note those. The vestibular ligament is your false vocal cord. It's not involved in voice production. Now, this is just isolated without the mucous membrane over it. When you put the membrane over all these things, it makes kind of a fold. So if you ever see the term false vocal cord or false vocal fold, it's all the same thing. I think they're all interchangeable. Vestibular ligament, false vocal cord, doesn't participate in voice production. False vocal fold, what you call it if the mucous membrane were over it. It's all basically the same thing. It does kind of help to guard the airway. It's like a shelf to catch stuff over your airway. I'll just put that as a note. Helps to guard airway, the glottis. Anyways, that's the superior ligament, as you can see from the picture. This bottom ligament, that's the true vocal cord, your vocal ligament. And you can call it the true vocal cord or true vocal fold for the same reason. You call it a fold when you put mucous membrane over a ligament. All right, let's move on. Here's a nice picture of the arytenoid cartilages, which are paired, singular here because you cut it in half, and then the little corniculate cartilage, the little horn tip at the top. Cornified, corniculate, it means horn-shaped. Here's the view we looked at before. I was talking about intubating. There's the tube there. You got to get it through there. So usually what they do is they have this metal blade. I've seen the paramedic students practice this on cadavers, which I prepared for them. That's one of the things I've done in the past. And with Jeff Changaris, they kind of like stick metal blade there, and they aim for a spot called the vallecula right there, and they just kind of like lift up a little bit, and they can kind of see that view. Okay, and they stick the tube down there, and when they practice, every once in a while you'll miss, and they go down the wrong tube. That's the food way. So then what do they inflate? Not the lungs, the stomach. And you can kind of see that because we have it all open. So you can see if the lungs inflate or if the stomach inflates. So, all right, so that's kind of an emergency procedure. Hopefully you never need that in your entire life, right? Here's our model. If you look down the gullet right there, that's kind of what you see. The whitish lines are the vocal ligaments, okay, or true vocal cords right there. Here's a picture of glottis closed, glottis open, okay? So when you breathe in, they open up, and when you talk, you exhale through this slit, and it vibrates the vocal cords, and that helps in voice production, okay? Here's that model we've been looking at. I like this picture because it kind of shows in this picture and this picture of a model. This top line right there, that's the false vocal cord, the false vocal cord or vestibular ligament. There's the true vocal cord. You can see there's a little shelf there, in part created by the false vocal cord. That's why that little shelf, I said, helps to guard the airway. So hopefully that picture kind of lets you see why. So in voice production, it's the intermittent, it's the release of exhaled air. Let's say that. Okay, well, when you open and close a glottis, open, breathe in, but voice production is when you breathe out. Upon inhalation, vocal cords are open and the air rushes in, and upon exhalation, the vocal cords close and the air is forced to whistle through a slit, vibrating the vocal cords, producing sound. And so the pitch of your voice, high or low, is determined by the length and tension of the vocal cords. The loudness depends on the force at which the air rushes across the vocal cords. And the pharynx nasal cavities, lips and other oral cavities. They help resonate, amplify, and enhance the sound quality. So, that's kind of why if you like, you have a party balloon and you suck in all that helium air, it makes your voice high and whiny because that density of air vibrates your vocal cords at a higher frequency. All right. So sound is shaped into language by the action of pharynx, tongue, soft palate, and the lips. So muscles of the larynx. Let's talk about a couple. All right. So for our laryngeal muscles, just know one on the front, one on the back. The one on the front is called the cricothyroid, named for its attachments, right? The cricoid thyroid cartilage. Then posterior cricoarytenoid, right there. Okay. So anatomically, those are good pictures to look at. And in terms of the innervation, these are all branches of vagus nerve, cranial nerve 10. Excuse me. The superior laryngeal nerve, right there, innervates cricothyroid. It's the external branch. You don't got to know that. Let's just call it superior laryngeal nerve. Know that it's a branch of the vagus nerve. So know the innervation. And I have this note here. Here's a dissecting aortic aneurysm. You can see how in the development they have to kind of loop under the aortic arch on this side. That would be the left side. And that can be a problem if you have a descending aortic aneurysm. An aneurysm is where you have a weakening of the vessel wall, and it's like it's about to burst, but it doesn't. But you want to catch it before it does burst. That will be lethal. So in an aneurysm, if you got a big bulge right there, it could damage these laryngeal nerves, and it might be present as a symptom. Maybe you have a hoarse voice or difficulty talking, breathing, whatever. And well, that might be a sign to the physician. We better get some imaging done. You might need emergency surgery. You don't wait for that one, right? Well, anyways, you put that as a note. So it may damage these they're called recurrent laryngeal nerves because they recur. They go under, then they recur by going back up. The left one, the left one because this one is on the left side. The right one doesn't loop under it. Only the left one does. So the symptom may be maybe a hoarse voice. Now, when working properly, this muscle contracts, and there's a little pivot point right there where they put the screw in the model and kind of tilts it forward just a little bit, tensing the vocal cords. That's the action. So if you just kind of, I feel kind of silly, but if you go, tense the vocal cords, making a high sound, you kind of feel it, right? Something's going on in there when you try to make a high pitched noise. You hit that high note, so to speak, right? Okay, that's the action. That's just a clinical side note, but just know all that and moving on. The posterior cricoarytenoid, innervated by, again, a branch of vagus nerve. These recurrent laryngeal nerves give rise to inferior laryngeal nerve. I kind of point to it there. It's going around back there to innervate that muscle. So innervation is inferior. When it innervates the posterior cricoarytenoid, the action is abducts vocal cords. And that's very important. I think this is the only muscle that does this. So when you abduct the vocal cords, you open them up so you can breathe in. So if you paralyze this muscle, you may have trouble breathing. That's why I want you to know it. So in the model here, these muscles, they pull them apart. And of course, I got to pull it, simulating the action of the muscle. You can see the vocal cords abducted there. Here's a model, I'm sorry. Here's a model showing you both nerves that you have to know. All right, so for our next slide, I want you to know Valsalva's maneuver, which is straining against the closed glottis. It basically splints the trunk during heavy lifting. You can see this picture here. Like kind of like when you lift something, you go instinctively, or even when you like go number two, empty your rectum, you go, you're increasing the intra-abdominal pressure to empty your rectum or to splint your trunk when you lift things. And it's basically what you see here. Um, I also know that it increases blood flow to the head. They use this as a training exercise for fighter pilots because the G forces in a fighter pilot, when they dip the fighter jet down, the G force down is so great. The heart has a tough time pumping blood up to the head because the force down is so great. So if you kind of go in the cockpit, you decrease the chance of blacking out. All right. So since we're talking about pharynx, glottis, all that, I thought this is a barium swallow, and it's good for you to watch to see some of the anatomy that we've been talking about. So you see the food go down there. Notice how mobile the soft palate is. You can see the epiglottis there. It's up, and you can see it really quickly go down to cover the airway when they swallow. You see the hyoid bone there. There's the laryngeal prominence. Let's move on to the trachea. That'll be the next thing after the larynx. And we have a simple picture here. We can see that the trachea goes, well, you could kind of tell in your own body. There's my laryngeal prominence, so I know the trachea starts right underneath that, and it ends right around here, just below the manubrium of the sternum. So right around here. I mean, it's not very long from here to here, okay, if you think about it. So for the first notes for the trachea, again, not very long, from here to around here, 4 inches in length, about 3/4 inch in diameter. Um, So here's a posterior view of it. Here's a cross-sectional view of it, where you can see posteriorly you have the esophagus. So here's the lumen of the trachea, and it's long, it's flexible, but it has these rings that keep it open during ventilating air through it. If you suck air through something, the tendency is for the tube to collapse. But because of these stiff cartilaginous rings, it keeps it open during ventilation or breathing. And I think what we learned from this cross-sectional view here is that it has three layers: mucosa, submucosa, adventitia. What we learned from a posterior view of it here, it's soft tissue in the back. This ring of cartilage isn't a complete circle. It's more of a C-shaped or U-shaped if you look at it this way. And this soft tissue here, so when you have a big bolus of food going down the food way, there's some give there. It's not a stiff tissue here, it's soft tissue. So let's talk about the tracheal wall. Basically tri-layered. Let's first talk about the histology. You can see the layers here, but in a closer up view of a histological picture there. Oh, let me move that up a little bit. A slight modification. So what we learned from this picture here is I just took a big, um, I just blew this up so you can see the tracheal rings here. So when you cut it, that's kind of what you see here, the cut tracheal rings, kind of matching the tracheal rings here. And we can see the tri-layered nature of the tracheal wall. It goes mucosa up here. From here to here is submucosa. Then from here on down is adventitia. Let's take a closer up view here so you can see things better, and even a closer up view so we could see the tissue type for the mucosa. So from here to here is what we call the mucosa. This is a mucous membrane that lines your airways. So tracheal wall, mucosa. I would describe the epithelium as a ciliated pseudostratified columnar ET with the goblet cells, which contribute to the mucus nature of this mucous membrane. Ciliated, and that's very important, ciliated, pseudostratified, columnar, ET, epithelial tissue, with goblet cells. Full long name, and underlying it is a lamina propria, a loose ET. So know that too as part of the mucosa. So you can see the cilia, you can see these goblet cells there, and that divot right there is not artifact. It's basically where a duct from the submucosa sends a duct up. So it helps also contribute to the mucus along with the goblet cells. Okay. Lamina propria right there, be able to identify that. Lamina propria. Here's another picture showing you the pseudostratified nature of this tissue there. Here you can see a gland, a seromucous gland from the submucosal layer leading up to the mucosal layer and secreting along the surface right there. And so you have to cut it in exactly the right plane to kind of catch this, and it's rare to see, so I included it in the lecture there. In this picture here, you can kind of see inside one of these glands there. I think that was a cool picture as well. All right. So going back to this picture, there's that same divot where you can see an exocrine gland, a seromucous gland would secrete right there. But you can also see from here to here is the submucosa with lots of mucus glands. I call them seromucous glands because it could be a combination of serous and mucus secretions. So I'll put submucosa with Seromucous glands. That's all you got to know about that. Anyways, there's a nice view of the ciliated nature of the mucosa there. And the last thing for adventitia, the only thing I really emphasize is, sorry to go back and forth like this big hyaline cartilage of the adventitia. There's other tissues there, but just focus on the hyaline cartilage of the tracheal ring for the adventitia. So tracheal rings, they are hyaline cartilage. Running out of room? I think I just made it there. Okay, well, squeezed it in. Once again, to review, mucosa, submucosa, adventitia. And everything I've noted here is all you got to know in terms of the contents. So I want to erase this. So the notation I have for a mucus escalator, just like an escalator at the mall, this one is talking about the escalator that goes up. All the cilia helps trap debris. Misspelled that. To help move it up and out of the respiratory tract. And so let's talk about the rest of the respiratory tract. And we kind of call this the bronchial tree, where we talk about all the conducting airways all the way down to the respiratory zone. This is the correct view of the respiratory tract. But because we call it a tree, I'm like, I don't really see a tree. Well, unless you turn it upside down, this becomes the trunk, and the dividing airways become the branches of the tree. So these things branch out. And the bronchial tree has something like 23 orders of branching after the trachea. You appreciate that the trachea is one airway that has to divide 23 times to get to these microscopic alveolar sacs. You have millions of them to ventilate fresh air so you can have the gas exchange at the lung so your blood can pick up the oxygen in the pulmonary circulation. Okay, so we like to talk about these 23 orders of branching. We won't do 1 to 23. We'll kind of skip as we kind of go. I'll just kind of give you a summary what's going on here, but we'll go through. We'll start with 0 and go to 23. The carina is the last tracheal cartilage ring, marks the end of the trachea and the beginning of the right and left bronchi. So by the time air gets there, air reaching the bronchi, it's warm and cleansed of impurities. It's saturated with water vapor. The bronchi subdivide into secondary bronchi, each supplying a lobe of the lungs. And well, basically, like I said, you undergo 23 orders of branching in the lungs. Let's kind of go through it. There's the carina. Note that. The last tracheal ring. The last tracheal ring, period. I kind of call it the underpants. You kind of see it there, right? Well, anyways, how we do this is we kind of like talk about division 0. That's the trachea. It's the airway, and it hasn't divided yet. In the first division, right, at the carina, you can kind of see it divide and divide and divide again. We'll just kind of go through it. So we'll discuss the division and the airway. So before the airway divides, call it division 0, the airway is the trachea. And I would say how this is your main conducting airway, and what we just discussed about it, it's a conducting airway. There's no gas exchange. We're just conducting the air down to the lungs, and it has a very prominent mucosa. I'll just say thick. Obviously, you have to know the details. It's got that stratified columnar epithelium. It's got the cilia. It's got the goblet cells. It's a mucous membrane. It's great for conducting air, but not for gas exchange. And it had very prominent cartilage rings, C-shaped cartilage rings, another prominent feature. It divides at carina. Then you get your first division. Your first division, which gives rise to the right and left bronchi highlighted in red here. So we'll just call it division 1. Okay. So in the first division, it gives rise to two airways, two bronchi. Those are your right main bronchus and your left main bronchus. There's the one on the left, there's the one on the right. Bronchus is singular, bronchi is plural. Well, no surprise, each of these bronchi are large airways. You still have prominent amounts of cartilage, okay? They're each delivering fresh air to the right and left lungs. It's basically what you got to know. Be able to identify the right and the left main bronchus. A clinical note is kind of look at the anatomical differences here. You got the aorta going over this one. It kind of goes more off to the side. This one is more, the right one is more straight up and down, more in line with the trachea. So say a small toddler, they always like to stick things in their mouth. They swallow a small peanut or something. It's more likely to get lodged down this airway, the right one, than the left one, because the right one is more in line with the trachea. So I'll just put it's more prone to be obstructed. The right one is because it's more in line with the trachea. You should note that. So the second division, you get the secondary lobar bronchi. They're highlighted here. Count them: 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. So we're on division 2. The second division, those two right and left main bronchi give rise to 5 lobar bronchi. The second division. you get 5 lobar bronchi. Looks like you got 3 on the right, 2 on the left. Notice how the cartilage, by the time you get to here, the cartilage rings are starting to become cartilage plates, not so much a full C-shaped ring. Okay, so you still have lots of cartilage, but you're starting to decrease cartilage, and you have cartilage plates, not so much C-shaped rings anymore. And so again, you got 5 total. Okay, you got 3 on the right, 2 on the left. And each of these 5 airways is supplying fresh air to a lobe of the lung. Each lobar bronchus is delivering air, assume it's fresh air, to a lobe of a lung. So that having been said, can you guess how many lobes are in the right lung? 3, and 2 for the left lung. Continuing on with the third division. Division 3. So those 5 lobar bronchi, when they divide, it gives rise to something like 19 or 20 tertiary bronchi. Sometimes they're called tertiary or segmental bronchi. Notice we're still calling them bronchi. It's still considered a bronchus, not a bronchiole. Not there yet. But the airways are getting smaller and smaller with each division. So in this one, it's already color coded for me, so I didn't have to do it. You can see they're numbered with Roman numerals. You don't have to know the Roman numerals. Just know that all the colored ones are considered the third division tertiary bronchi, or you can call them segmental bronchi, because each airway, each of these bronchi, each airway is delivering air to a segment of a lobe. As you can see from the picture, it's color coded. So for example, this airway is bringing air to this segment of this entire superior lobe. You still have prominent amounts of cartilage, although it is decreasing. Cartilage still present. And with each division, you're starting to decrease the amounts of cartilage. Eventually, you want to get rid of it altogether, but right now it's still there. And this is still divisions 1, 2, and 3. We still call this the conducting airways. Okay. I've also heard that um, this anatomy can be useful to surgeons who have to, say, remove or resect part of a lung, maybe due to a tumor or cancer or something like that. They can use the bronchopulmonary segment, that's what it says there, as an anatomical guide, because if you remove the segment with the airway, you're also getting all the blood and everything else. It all comes as a unit: the blood supply, the airway, the lung tissue. Okay. All right, we're moving on here, and then we're going to talk about the rest of the divisions. We only got to Division 3, but to kind of be quick about it, we can't go all the way 1 to 23 one by one. We can kind of summarize here. So in this picture here, what they've done is they've taken a larger airway, a larger bronchus. That's what the number 1 is. And you can see you get the smaller bronchioles. And you can see that you have the conducting zone. And then way down here, you have the respiratory zone. This is where you have those tiny air sacs, the alveolar spaces. That's where the membrane is thin enough. It thins out enough so you can have gas exchange across it. And they've kind of pruned down all the airways so you can see that the respiratory tract, it's a dead end. It's not a circuit like the circulatory system. Blood goes round and round, air goes in and out. Okay. All right, so our division, we left up at 3. So let's say like divisions 4 to 10, you know, around here. What you should notice is you have subsegmental bronchi. Before we had segmental bronchi, now we have subsegmental bronchi from 4 to 10, called the airway. Subsegmental bronchi. The airways are getting smaller, you're still decreasing the amount of cartilage. Still considered your conducting airways because there's no alveolar spaces yet, okay? Still part of your quote unquote conducting airways. So as we're thinning out here, the airways are getting smaller, the mucosal layers are getting smaller, but there's still some cartilage here, okay? All right, we're going to continue on here. My AirPods died, so the audio will be not quite as good, but just for the rest of this lecture, it'll be okay while they recharge. Well, anyways, 4 to 10 subsegmental bronchi. Yeah, and then from division 11 to about 16, that's when we first start to have the bronchioles. So let me find my pen. 11 down to 16. Bronchioles, the smallest airways. We're still in the conducting zone, but these airways, pretty much starting from here. So conducting airways here, bronchi all the way up to here, and then bronchioles starting from here. It's still all conducting airways. There's no alveolar spaces yet. So, but the bronchioles, they're cartilage free, no cartilage. And you have increasing amounts of smooth muscle. Now, smooth muscle can be controlled by the autonomic nervous system. So the sympathetic nervous system, the SNS, it can vasodilate. It can open up those airways. Oh, I'm sorry. We're going to call it, excuse me, bronchodilate. And the PNS, bronchoconstrict. I mean, not to the point of being asthmatic, just normal opening for normal airway flow. So that's bronchiole. So bronchi all the way up to here. Then you can see there's no cartilage from here on out. They get rid of the bluish illustrated cartilage tissue. So this is important because you can control the airways with the autonomic nervous system. Oops, sorry. Okay. At around right here where they have number 5, the terminal bronchioles. It would be around where we left off, division 17. They're just bronchioles, but we call them terminal bronchioles because, well, it's the end of the conducting airways. Where they have the number 5 there. So after that, you're going to have the respiratory zone. So pretty much the respiratory, excuse me. Actually, maybe one slight modification here. Let's call this number 16, okay? Kind of where we left off. All right, so we'll call that number 16, the terminal bronchioles. And then we'll make, starting from 17, the next 3 divisions, like 17, 18, and 19. We'll call those the beginning of the respiratory zone. And these 3 divisions are called respiratory bronchioles. Okay, so 16, terminal bronchioles, end of the conducting airways. The respiratory bronchioles is the first place you'll have alveolar spaces. So this is the start of the conducting zone. I'm sorry, the respiratory zone. You can have gas exchange, and what they do as a favor, they kind of blow that up in other figures. But you know, in the lab we have this too. We have a picture of that. It's the same thing. So I like to use either image for tests, lab practicals, whatnot. Well, anyways, if you just kind of look at this portion that got boxed here, we can blow it up, and we can see that these respiratory bronchioles, if you see those little air bubbles, those are alveolar spaces. So you can call it a respiratory bronchiole. And you can see a couple of things here in the respiratory bronchioles that I'll add. You see smooth muscle and elastic tissue, increasing amounts of those. So the connective tissue structures are changing. In the beginning, in the large airways, the conducting zone, you had basically big cartilage plates. But as you get down to the smaller airways, we see that you have increasing amounts of smooth muscle. As we said before, I'll say it again. And more elastic tissue, because your lungs are like an inflatable balloon. Elastic fibers. It's like when you blow air into a balloon and you just kind of let the air out, it collapses to push the air out. Your lungs are kind of like that. Breathe in and just let the air out. The elastic recoil of all this elastic tissue here that you see right here, it's the little purplish lines you see around the airways and around here too. And the more pinkish tissue here, that's the smooth muscle. So take a close look at that picture. Print it out, take a close look, and make sure you can identify smooth muscle versus elastic tissue there. So division 20, 21, and 22, we'll just call them alveolar ducts. Imagine the duct is like a hallway, and the hallway has all these rooms in it along the hallway, and then you can go into a room through a sliding glass door or something, and then the rooms represent the alveolar spaces. So that'll be the last division. Alveoli, plural. Alveolus, singular. And by the time you get to here, it's the individual little tiny air sacs there. And there's some substructures here you should know that in many alveoli create an alveolar sac. You can see the duct right there. Okay. But many alveoli, I think of it as grapes. Like one grape is an alveolus, but many grapes, a cluster of grapes, makes this structure here called an alveolar sac. That many clusters of grapes form this structure here, number 7, acinus. Many alveolar sacs form acinus. So the structure are acinus, alveolar sac, alveolus. But pretty much that's it. That's the dead end. Fresh air ends there, and the alveoli form the all-important respiratory membrane where gases can be exchanged with the pulmonary blood. Form respiratory membrane for gas exchange. All right, the details of gas exchange we talked about in another lecture. Continuing on to the next slide, the summary page of the bronchial tree, starting with division 0, going all the way to division 24. I stopped at 23. Different books differ. Doesn't matter. You're usually off by a couple. Anyways, and well, anyways, I didn't emphasize the numbers. I thought I'd do that here. I think it's amazing that this bronchial tree, you have one airway, goes through 23, 24 orders of division. You have as many as 40,000 subsegmental bronchi. Just got the numbers off here. 40,000 that are division 6 to 11. And look at the bronchioles. You get as many as 8 times 10 to the 7. 80 million bronchioles. It's a lot. In your final division, I think this is remarkable. As much as 6 times 10 to the 8 alveoli. That's 600 million alveoli. Okay, that's a lot of cross-sectional area right here. And that's really what I have emphasized here. So you have one airway, 2.5 centimeters cross-sectional area. But this provides a lot of cross-sectional area for the respiratory membrane. So moving on, let's talk about the anatomy of the respiratory membrane shown here. We have our alveolar space. You can see at these little corners here we have the pulmonary capillaries for the gas exchange. We have our different cell types in this space. There's basically type 1, type 2 cells, and we'll go through that. So let's kind of look at the membrane itself. When we say respiratory membrane, we're talking about this thin membrane where gases can be exchanged across. So the main cell you see lining here is this type 1 cell, type 1 alveolar cell. It's the main cell of the alveolar space. This is basically an epithelium, and we would describe it as a simple squamous ET if this were a histology class. So the respiratory membrane, just the type 1 alveolar cells, the main cell, it forms a simple squamous epithelial tissue. So if I draw this cell here as an epithelial cell, squamous cell, kind of go like that. There's the nuke. It's kind of connected to the endothelial cell of a pulmonary capillary. I'll use red. And they're connected by this fused basement membrane right there. Fused connective tissue. So that's it. Those three things are the respiratory membrane. So to be clear, the respiratory membrane is formed by, number 1, the alveolar cell, type 1. Number 2, I say alveolar epithelium, same thing as type 1 alveolar cell. And here, the capillary endothelial cell right there. So I'll say that. That's for my number 2. And then number 3, that I used in blue, the fused basement membranes of these cells that kind of fuse them together, forming a single respiratory membrane. It's membranes plural because it's the basement membrane of this cell and that cell. But I just kind of drew it as one thing. It's fine. The point is that this is thin enough so gases can be exchanged across it. And the beauty of this system is those, what is it, 600 million alveolar spaces. I mean, that's a lot of cross-sectional area for gases to be exchanged across. So know the anatomy of the respiratory membrane. Here's a picture of a model you can study. Well, let me go back to this one. I didn't teach the type 2 cells yet. So let me erase this. So the type 1 alveolar cell forms the wall. The only cell types I don't want you to know are type 1, type 2, and alveolar macrophages. So the type 1 cell forms the wall, alveolar wall, that is. Type 2 cells, they're surfactant secreting cells, right there. They're more round. They used a color green there. They secrete surfactants. And surfactants help decrease the surface tension inside the alveolar space. Decrease surface tension of water, H2O, lining alveolar spaces. This makes it easier to breathe, especially when you're born into the world. So imagine this is the alveolar space. It's lined with water. So imagine all these water droplets forming a thin layer of water. And what you want to do is you want to interrupt, you want to get between the water molecules. So pretend that's a surfactant. And by inserting yourself in between water molecules, you break the surface tension. Because otherwise, if there are no surfactants, the force would collapse because there's a force in, because there's a cohesive attraction between water molecules creating the surface tension. And with no surfactants, it's more difficult to breathe because you have to overcome greater surface tension forces. You break it up with the little green balls there. They have an ability to intersperse between water molecules. This is basically how laundry detergents work. Laundry detergents, by basically breaking up the water molecules in your washing machine, you're decreasing the viscosity of water. You make it better for the water molecules to penetrate the fabrics to get the dirt out. Okay. Also now, alveolar macrophages. Shown these cells there. As a third cell type, I guess. Type 1, boom, boom, also known alveolar macrophages. Keep things sterile. Okay? One other thing to notice is that the type 1 cells are more flatter. The type 2 cells are more round. And it's hard to see here, but I'll point it out to you so you can kind of look and not be fooled later. Pay close attention. There's a type 2, more round, a type 1, more flat. And I'll blow that up so you can see it better. Type 1, more flat. Type 2, more round. All right, moving on. The whole more flat, more round thing. In this next slide, we can kind of see how I really blew it up. It gets a little pixelated and blurry. The type 2 more round, type 1 more flat. Okay, to match those notes right there and right there. There's an alveolar macrophage, although I didn't label it. And I think I glossed over the pulmonary circulation, so if you'll pardon me, I'm going to backtrack in case I did forget. I don't think I talked about this, so let's go over to be sure I did. It's covered. Now, I should be able to be quick about this because we covered pulmonary circulation, we covered the heart and the blood vessels, but we never had a picture like this. So note that this tissue needs a regular blood supply, and that's the bronchial artery right there, just supplying blood to all this tissue here. So that's not a part of pulmonary circulation, so I'll put it in parentheses. It's just part of regular systemic circulation. So in parentheses, not a part of the pulmonary circulation. But what is, see the bronchial artery? So the bronchial artery, it follows the airways. Branch of pulmonary
arteries carrying deoxygenated blood. I think I said pulmonary the first time. Branch of pulmonary arteries carries deoxygenated blood. Follows the airway. Branches out into these little pulmonary capillaries. And then the pulmonary veins on the sides off the airway will drain into the pulmonary veins. Okay, so it goes to pulmonary capillaries. That's where you have the gas exchange. You should already know that. And that leads straight to, so boom, boom, boom. That leads straight to branch of pulmonary veins off of the airway. Okay. From this model here, there's the bronchial artery, pulmonary artery, pulmonary vein. It's hard to see. The thickness of that wall is thicker. That's an artery. It's a vein. It's blue because it's deoxygenated. So old blue pulmonary artery, red pulmonary vein, bronchial artery. You can kind of see in this model here, if you see cartilage, it's a very small bronchus. If you see a tiny little air sac, that's going to be a respiratory bronchiole. So the bronchiole right before it would be a terminal bronchiole, because then it gives rise to a respiratory bronchiole just right after that. And you have this picture here too, which you can study. We kind of went over it when we went over the other airways. All right. Talked about that. In terms of the histology, so we're deep in the lung tissue. This is the histology you're supposed to be able to identify. The name of this slide, if you were to study it in the lab, would be the bronchial lung tissue slide. And so just know these structures. Alveolar duct, alveolar sac, bronchiole, alveolus. Just listing them and not in any particular order, but they're labeled there. The bronchiole, you can see this thickened mucosa there. So now that's bronchial. See how it divides? And as soon as it gets to here, from here to here, alveolar duct. You have a lot of alveolar ducts here. This is alveolar duct. That's alveolar duct, all right there. Here's an alveolar sac. And you can see the little dead ends, the alveolar spaces. So if I just point to one little space, that's an alveolus. There's the picture unlabeled. Here's a closer up view. All of this, the hallway, alveolar duct, alveolus. This is a nice alveolar sac. Yeah, it's pretty much all of this is alveolar duct too. Pretty good picture. There's an unlabeled one. You can quiz yourself. Here's a bronchiole, and I want to do a close-up of the wall of a bronchiole. And so for the bronchiole slide here, I labeled number 1, number 2. Number 1 is the epithelium of a bronchiole. It's not a pseudostratified columnar, it's a simple columnar ET. Okay, so it's not a pseudostratified columnar like it was in the trachea. It's simple. I'm going to call it simple cuboidal. And add this with sparse cilia. That's usually what we see at this level. And you see a lot of smooth muscle, no cartilage. So note that. I just wanted to put that side by side. This is unlabeled, we already went over it, but that's a ciliated pseudostratified columnar ET with goblet cells, and there's ducts that lead up to there. You can kind of see the difference as you kind of start to thin out from here to here. Let's talk about the lungs as a whole. When you remove them from the chest cavity, this is what you got. Pretty simple organ to look at when it's removed. This is called this is basically the front. It's called the costal surface. Costal means rib. It's the part that's facing out, touching your rib cage. Well, anyways, there's some differences between the right and the left. You should be able to tell which one. These lungs, man, I've seen chest cavities open. They occupy the whole area. Okay, there's still room for your heart and esophagus and trachea and other things. These occupy most of the space. They go all the way up to your neck. When you inhale, inspire air. Inspiration, breathe in. Expiration, breathe out. That's what we call ventilating the lungs. You ventilate these things. Inspiration. Breathe in. Expiration. Breathe out. So I'm trying to jam some stuff in the middle there. The ventilation is the simple act of breathing. Excuse me. But you don't assume gas exchange is happening. If there's pathology, it may not. Okay, some kind of pneumonia or something else impairing the gas exchange, like emphysema. We'll get into that later. But assuming no pathology deep in the lung tissue, if you ventilate, gas exchange is occurring across the respiratory membrane as we studied it. So anyways, anatomically pretty simple. The right lung has 3 lobes, 2 fissures. The left lung has 2 lobes, 1 fissure. The 3 lobes are superior, middle, inferior. Lobe. And for the left lung, the 2 lobes is just superior, inferior. So be able to identify superior, inferior lobes on this side, and on the right side, superior, middle, inferior lobes. The 2 fissures, a horizontal and oblique fissure. And on the left side, 1 fissure. The right here, 1 oblique fissure. Okay, because it's more oblique, less horizontal. That's basically what you got to know for that on that surface. But if you turn the lungs in, this inner part where you have the hilum is the inside part where things enter and exit. You should be able to identify, well, what's labeled here, pulmonary artery, okay, pulmonary vein, and the airway. Those 3 things on both sides. So helum and helum, be able to identify pulmonary A and V and the airway, the bronchus. We'll pick it up here for another lecture.